Normally, the spine has to be straight or balanced. If you find a rotation or a curvature of over 10 degrees, then that's considered scoliosis. If it's less than that, then that's considered a listing. And normally, the spine has to be straight or balanced. If you find a rotation or a curvature of over 10 degrees, then that's considered scoliosis. If it's less than that, then that's considered a listing. It could be structural or functional in nature. Functional meaning it's performance or it's muscle based. It's not permanent. It could be fixed. A structural type of scoliosis has some sort of deformity in the spine or a structure nearby, causing the curvature. If we're talking about the bigger type of scoliosis, or the more prevalent type of scoliosis that's being shown around, we consider that as idiopathic scoliosis, right? Idiopathic scoliosis just means they don't know, or we don't know what's really going on. There's a scoliosis, unknown cause. That's the majority of the type of scoliosis that we see. Now, when you look at x-rays, that's normally not true. There is some sort of a muscular dysfunction seen, well, clinically, but back to x-rays, you could usually see something lower down in the spine. So although x-rays are usually diagnosed coincidentally or accidentally when a lot of people go for a chest x-ray as a requirement for work. So when they take an x-ray beam here, they're trying to get the lungs to see if there's something going on, and then they say, oh, my scoliosis, there's a scoliosis going on here. But a lot of practitioners treat where they see the scoliosis. If this is up here, then they would know what's the cause of that. They would call that idiopathic scoliosis. But a lot of times, for these kinds of scoliosis, the problem would be down here. Either there's a true short leg, something wrong with the pelvis, or quite usually this segment of the spine has something inborn, meaning to say, like it's like this piece of the bone here would be fused or closer to the side, so it would move properly, and the muscles in this area would have to move extra hard, and it would curve one way, and the body does not like that. It doesn't want someone curved this way, so it will make another curve of the opposite direction on the upper part, and that's why you see a lot of these idiopathic scoliosis. So to get to what type of scoliosis there is, more studies have to be done, and the easiest, most accessible way of doing it is get an x-ray, and in the right areas too as well. So people ask, what are the components of a scoliosis, because that would be in relation to how one would treat the scoliosis. Now, if you're talking about the spine and the curvature of the spine, when people see a scoliosis, they usually think, oh, it's curving one way like this, or what we call lateral bending, or curving the other way. Now, there in any type, well, not every type, but for the most part, when the spine has some sort of dysfunction, the spine is a three-dimensional plane. It's not gonna just go this way and that way. So there is a posterior component to it. Sometimes, most of the time, but not always, but it's coupled with a rotation. So it goes around like this, and then it laterally bends like that. So to treat a scoliosis, one has to address the posteriority, the rotational component, and the laterality, or the lateral side, the side bending part of the scoliosis. Now, to address that, it depends of what is the cause of that scoliosis. If it's a muscle imbalance, then one side would be tighter than the other, so the tight side should be stretched a lot, and the weak side should be strengthened so that it would start becoming straight again. Now, if the problem is down here, and there's usually a problem in this part of the segment. Now, what I'm saying is, if there's a structural problem, a lot of people think that, okay, there's no way to correct that, but the real way to check if a scoliosis is treatable or not is to get an X-ray, and it's a special type of X-ray, but it's not a special device that does that. That's just the X-ray, and the position of the patient has to be measured. So if the straight up X-ray has the scoliosis, we have to have another film which the patient goes one way like this, and then they take the film, and then they go the other way, laterally bending, take the film. Now, if there's a view that one side bending resolves or reduces the scoliosis, then we know that that's the amount of correction that could be made. Some practitioners consider that the minimum amount of correction that could be done. I'd like to be more conservative and say that's the maximum amount of correction that could be done. Let's say you have a curve that is like 30 degrees, and then the X-ray with the bending showed that it went down to 15 degrees when bending sideways, and we would tell the patient that 15 degrees is the maximum you could get out of treatment. Because if the patient curves one way and then the X-ray just shows it's the same thing, no change, then realistically you could treat as many times as you want. That's not gonna fix itself. Not without some very invasive procedures like surgery. And speaking of which, the next question would be, is it treatable conservatively? And that depends on the type of scoliosis. That's the answer to the question. Is it resolvable with that lateral bending, at least partially? If it's partial, then that's the amount of correction you could get conservatively. Now, normally 28 to 30 degrees of scoliosis and above, that will be for a bracing type of consult, and 14 degrees and above, that would be for surgery. Now, there are patients that opt not to go for surgery, and it's totally understandable. So again, the way to check if it is resolvable would be to simply get the lat bending x-rays first before doing any drastic measures. If there is no change and it's pretty high, then yes, the recommendation would be for surgery. The usual type of surgery done for a scoliosis, if it's, let's say it's very severe, they would put a rod going up called the Harrington rods. Now, nowadays it's less and less, and as advancements are made, it's less and less invasive. So the medical field has stuff that helps with that. Just be aware though that once you put a rod and to correct the scoliosis, the top ends and the bottom end of the rod because now the spine's not moving because there's a rod there. So wherever the rod ends, that segment above and below would have to pick up the slack for the lack of movement of that spine. So that upper part and that lower part would usually be dysfunctional. The muscles would be overworked. The structures, the joint in that area would be usually inflamed or get inflamed. And that's what we treat. There are patients that have that. So we can still treat those kinds of patients for that kind of pain that usually develops. But if it was my opinion, like I said, there's no problem with surgery if it's warranted for. So we have to do the proper testing first before doing anything, whether it's treatment or correction conservatively or more drastically, which is a referral out in our clinic. That's how we deal with that.